Hello, you are listening to the Charles Bonnet Syndrome podcast. My name is Shaimond, and today's special guest is Aysha Kinakool. She is in her final year as a PhD candidate at York University with a special focus in neuroimage techniques such as fMRI and spectroscopy. She has a focus on brain network connectivity and neurochemical levels in Charles Bonnet syndrome. So that's definitely a mouthful. And I'm glad that we have her here today so she can talk about all of the things that she's doing. So how are you doing today?
Good. Thank you for having me, Shaimond. I really appreciate the invitation and I'm excited to our discussion.
Oh, I'm excited to have you too. So can you talk a little bit about your history and what you've done? Because I understand you have another master's degree and you've had a journey to this point where you're at.
Yes. So just to give you a little bit of a background, I started my career as a physiotherapist. I got my bachelor's in physiotherapy and then I got my master's in neurological physical therapy. And at the beginning of my career, I worked in neuro rehab. So I saw neurological patients, stroke, multiple sclerosis, Parkinson's disease, and so on. And then I transitioned into my PhD, and that's when I got into vision science because my program was under the Center for Vision Research at York. And so I transitioned into vision research, and that's when I started my research work with Charles Bonnet syndrome.
So how did you first find out about Charles Bonnet syndrome?
So interesting enough, I had never heard of it. For sure, in my neuro rehab career and in my education during my bachelor's and during my master's, I hadn't heard of Charles Bonnet syndrome at all. It was only after I joined my PhD at York University that my supervisor, Dr. Jennifer Steeves, she first introduced me to Charles Bonnet syndrome, and she had several collaborators from the Canadian National Institute for the Blind. And we sat down together trying to figure out my research project. And that's when we decided that since I have experience with patient populations, that it would be a good fit for me to work with patients, CBS patients. And we started our research project. And that's when I started reading up in the literature about Charles Bonnet syndrome, about the fascinating manifestations associated with CBS. And I just took it from there.
So can you talk about what specific research you're doing now?
Initially, actually, during my master's degree, I had a focus on non-invasive brain stimulation techniques. So those are brain stimulation techniques that are completely non-invasive. They're not surgical procedures, no incisions, nothing. They're just to stimulate the brain through the skull. And when I transitioned into my PhD, I actually applied under Dr. Jennifer Steeves' lab because I knew that she had done work with TMS or transcranial magnetic stimulation. And it was of interest to me at the time. And so that's the main reason why I joined her lab, to be honest. I was fascinated by the work that she was doing. And as part of that, of course, as I told you, I've had a background with patient work in the past. And so for my research project for my PhD, we initially thought of doing a neuroimaging study where we scan the brains of people with CBS and measure their neurochemical levels. We also initially intended to start like a pilot study for TMS, for the use of TMS to potentially mitigate or hopefully eliminate CBS hallucinations. But unfortunately, the COVID-19 pandemic hit and the labs were shut. And so we had to pivot. So we started off with an online study first, where we looked into the quality of life, anxiety, and loneliness in people with CBS. And we wanted to see if those factors could potentially influence the hallucinations in any way, whether they could increase or decrease the hallucinations in any way. And from there, after the COVID-19 pandemic, when everything was up and running again, we started our neuroimaging study where we put people in the scanner to do a resting state functional MRI study and to measure their chemical levels in the brain, basically, and compare them to people who do not have CBS.
What are some of the challenges of doing a CBS study? Because every condition or disease is unique. And I was just curious, what are some of the challenges you're facing?
So I would say that one of the biggest challenges is the age of the patient population, I'd say. So as most of the people with CBS, they're usually above 70 years of age. Now, of course, there are people who are younger who develop the CBS, but the majority of people are above 70 years of age. And in order for us to include them into the study and to have them get into the scanner and get scanned, there is a very rigorous, and of course, above 70 years of age, there would be so many different comorbidities, maybe even implants in their bodies, whether it's a stent or a pacemaker or hearing aids. And all of those things would exclude them from being included in our neuroimaging study. And it's quite challenging to find people who have CBS, but who also meet all the criteria for them to be able to participate in our study. So I would say that's the most challenging part. Working with patient populations in general is always challenging because you need to collaborate with different research centers and hospitals to be able to get a good database with a lot of patients. But adding the age factor to it, I think that's the most challenging part of our work.
I'm glad that you pointed out that people can get CBS at a young age too, because I've spoken with people that had it when they were children. But I guess the reason that it seems to be more people who get it when they're older is because your vision starts declining when you're older, or you can start to develop eye diseases as you get older. So I'm glad that you mentioned that.
Yeah, it's a big misconception. A lot of people think that it only occurs, I don't know, above 65 or above 70 years of age. But even in some of our studies where, for example, in our survey study that we had people in their 30s and 40s as well who had CBS. So it's definitely not exclusive to people who are older. Yeah, and people who are younger could definitely experience Charles-Bonnet syndrome as well.
When you have a study, and let's just say that you have 10 people that are over 70, can you get some other people to join that study that are maybe in a different age group? Or do you got to keep people in the same age group and the same sex to make sure that the numbers don't skew?
One of the most important parts when you're formulating your study and setting up the protocols, it's very important to keep things consistent. So if you have, let's say, a patient or a participant who's 30 years old, and you have another one who's 70 years old, their brain chemistry, their brain structures are completely different. In fact, it has been well documented in the literature that with every decade of life, there is a 5% decline in terms of the structure of the brain, where the brain starts to atrophy or it starts to shrink. So you can imagine from 30 to 70, that's a huge jump, right? And so we usually try to keep things consistent. So if the majority of our patients are, let's say, between 70 to 80, then we try to keep it within that age range. And if we do want to add people from a different age range, then we add a whole separate group that's a younger age group, let's say, just to keep things consistent so that we can compare the groups, keeping in mind that their age could be a main factor that could explain the results or differences in results, basically.
So what made you focus on Charles-Bonnet syndrome when there's so many things that you can study?
Honestly, it was the fascination of CBS. I had never heard of it. And once I started reading more about it, and as it's not a new phenomenon, it was first documented by Charles Bonnet in the 18th century. It's been around for a very long time. And despite that, there's so many question marks. There's so many things that we don't know. And again, it's just, I guess it's maybe the researcher's ego where you want to make a difference. You want to look into the gaps in the research, in the literature out there, and you want to make a difference. In general, I specialized in neurological physical therapy, so I had an interest in neurological disorders anyways. And adding the whole visual hallucinations aspect to it and the fact that they know that the hallucinations are not real, it was just fascinating, their experiences and how it's highly subjective. Like one person has, for example, scary or frightening hallucinations, and the other person finds the hallucinations completely amusing and exciting. Just the level of variability between people and how there's not enough research on the different mechanisms that could cause CBS, or the different mechanisms that could explain the variability in manifestations. It was quite fascinating for me, honestly, and I just wanted to explore it a little bit further and to add a little bit more to the research that's out there.
So it's interesting. You mentioned how some people actually enjoy their CBS and some people it actually frightens them and it turns their life upside down. So in your study, do you have people that are on both ends of the spectrum?
Yes. In our first study that we conducted, the survey study, we had a very elaborate, detailed screening questionnaire, and it asked them all sorts of questions about their experiences. They had the ability to write paragraphs about their experiences. And just looking at the amount of variability from one person to another was honestly mind-boggling. There are people who actually look forward to their hallucinations. They actually wake up in the morning looking forward to their hallucinations because they're entertaining, because they're amusing. And on the other hand, there are other people who are extremely stressed and extremely anxious because of how scary their hallucinations are. So you definitely see both people who enjoy them and people who completely despise them. And yeah, it's not rare. It's not rare to find people who are extremely frightened or who think that their hallucinations are unpleasant. It is out there.
Now, this work that you're doing, is this like your thesis for you to become a doctor, or how does the process work with your research?
Yes. So my research is part of my dissertation. So it's part of me completing my requirements towards my doctoral degree. And normally for you to get a doctorate, you would need to have a series of studies or like a compilation of several studies. And luckily, all the 3 studies that I've conducted are actually involving Charles-Bonnet syndrome. So that's exciting and interesting.
That's great.
Yeah.
That's so great that you have an interest in this. You are researching, and like you say, there's multiple studies that you're doing. We need more people like you because even doctors don't even know about this condition. So when we have someone like yourself who has taken an interest in this and is really trying hard to do some research to get some answers and bring some relief, hopefully, I commend you for that.
Thank you. I really appreciate it. And yes, a big part of my CBS journey, I would say, is just knowing how much of a lack of awareness there is out there about CBS. There was a study that was published by Dr. Keith Gordon. He used to work with the CNIB, and it found that in Canada, 55% of family physicians were actually completely unaware of Charles-Bonnet syndrome, which is quite sad because that means that 50% of patients who seek help actually do not get relief from speaking to their healthcare providers. And it's really a scary thought. And so it's very important to increase education, to increase awareness about CBS, because research has also shown that proper education to CBS patients helps them alleviate their fears, and it just helps them manage their symptoms better. So there's definitely a lot of work that needs to be done.
I was just thinking to myself today that Charles Bonnet actually discovered this, like you said, in the 18th century. He discovered it in his grandfather. And then years later, I believe he had cataracts and he started experiencing hallucinations himself.
Yes.
I'm wondering, is there any literature or anything that you're familiar with, any research articles or something that maybe discusses the possibilities of it being genetic? Because they're both in the same family and they got it.
So I don't think research focuses on genetic aspects of it. And I'm not sure if I can answer that question. I don't know. Maybe there could be a genetic predisposition to CBS, but I don't know if it's directly linked to the hallucinatory manifestations. Maybe the genetic aspect, and again, I'm not a neuro-ophthalmologist, so I cannot speak about this, but maybe the visual disorders, like, for example, age-related macular degeneration or glaucoma, if there is a genetic aspect that predisposes people to developing those conditions, and knowing that those conditions could result in CBS hallucinations, then in a way, yeah, maybe there is a genetic aspect to it. But in the literature generally, when we speak about the etiopathology or the mechanisms that cause CBS hallucinations, genetics are not one of the things that are usually discussed.
Okay. Thanks for letting me know that. And I think it's always good to stay curious, and probably, I don't know how you will feel about this, you and your colleagues, but probably always good to keep your ear to people that are maybe not doctors. Because as a doctor, whether it's a PhD or medical doctor, you may have a certain mindset potentially, and you have your training, and then you have someone else that doesn't know anything about that. They could say something that could be like outrageous, but maybe out of
Yeah.
the 10 outrageous things they say, maybe two of them could be something that's worth thinking about. And it's good to have a mix of people around you so you can just get a different perspective. I'm thinking, I don't know.
100%, especially when you're working with patient populations and especially when you're working with a vulnerable segment of the society, right? When you're talking about people who are older, above the age of 70, you have to keep in mind that their experiences matter. And whether it sounds outrageous or not to you as a professional or a healthcare provider, it doesn't mean that we should just ignore their experiences or the things that they express, right? A part of research is that you have to keep an open mind, and you have to keep an open perspective basically about the possibilities that are out there, because maybe something that may sound outrageous to you, maybe there is merit to it. It's just never been studied or never been discovered, right?
As I was reading and traveling, I understand that in some Asian countries, particularly like Japan and stuff, they really respect their elders and they hold them in high esteem. And in some other countries, elderly are not really treated that well. They're kind of in these old folks' homes, for lack of better words, and they don't get treated well. Sometimes they're living in a bad situation. So I was wondering how professionals would treat Charles Bonnet syndrome from country to country. I don't know if you have seen literature from different countries and you see a different approach, or is everybody's in agreement right now with Charles Bonnet?
Unfortunately, I don't think there's a lot of research from the East, I would say. Most of the research that's been published, of course, we know from the Americas, from Europe. There are a lot of amazing researchers who do a lot of work with Charles Bonnet syndrome. I don't know if the cultural aspect of treating elders or how they end up in nursing homes or not, how that could affect the prevalence of the disease, or how, whether it's reported or underreported in those countries. But yeah, generally, I would say there's not much research that you see from the East. You don't see research from Japan or maybe from the Middle East. You don't really see a lot of research about Charles Bonnet syndrome. So that definitely raises a lot of red flags. And I think it also highlights that we have a lot of work to do, not just in the West. We have a lot of work to do internationally to raise awareness. Because if in North America, if still in Canada, 55% of family physicians don't know about CBS. So imagine in countries where there is no CBS research, imagine what the prevalence of CBS is, or the lack of awareness amongst physicians is over there. So definitely we need a lot of awareness internationally to be able to help people all around the world. In fact, just recently in 2022, the World Health Organization released in their report that about 2.2 billion people around the world have some form of visual deficit. Now, of course, the majority of them just have minor to moderate visual deficits like farsightedness or nearsightedness. But then, despite that, 43 million people around the world are blind. And we know that as time passes by and as the aging population increases, the prevalence of blindness is going to increase. And we know that more and more people are going to start experiencing CBS, because there have been reports that 1 in 5 people with vision loss have visual hallucinations. And so it's definitely not just a local problem, it's an international problem, and we need to promote awareness about CBS everywhere.
One thing that we've been discussing on this podcast, me and the guests, is getting some literature into the doctor's offices, even if it's just the ophthalmologist, because you have to have a visual impairment to actually have CBS. So if you have some pictures on the wall, or maybe not pictures, pamphlets, or some kind of information that someone can see, even if it's written in Braille, to let people know that this is a possibility. But I was thinking, since you mentioned something that it seems to be a fact, that majority of the people, at least that we know that have the condition, are older. maybe in senior homes or senior centers, they can put something out and just say that if you have a visual impairment and you see something, it's something called CBS, and just take this information, either whether it's for yourself or someone else, because there's other places beside an ophthalmologist's office where we could spread awareness, and people are suffering. And most of the time, when people either hear like Oliver Sacks' TED Talk about it, or someone out there that is actually doing a talk about it, they say, you know what? I think I have that too. Thanks for telling me. Even if it's one person out of 100, and that can really help them, because a lot of people think they're losing their mind when it's happening and they're scared to talk about it. So I was just thinking that could be another avenue to help spread awareness.
No, for sure. And I think that there are people who are doing some great work. I know in Canada, the CNIB has been doing great things. They have support groups, and Lucia Ricardo has been doing some great work organizing CBS Awareness Day, where they have sessions with CBS patients where they can come together and just talk about their experiences. And it's very helpful, one, because it spreads awareness, because people talk and they go tell people they know. And also people who are experiencing CBS can then have an outlet where they can come together and they can talk about it more. So yes, definitely. I do believe that it's very important. I think that there are people who are doing some great work out there. But yes, we need to do more. That's for sure.
Can you discuss some of your findings, or is that private, or are you still developing and putting the information together? Can you discuss some of the findings of your studies?
No, for sure. And I think there's so many nuances to research. And so one of the techniques that we use is fMRI, which is a neuroimaging technique. So you may not be familiar with the differences between structural MRI and fMRI. An MRI that usually physicians or maybe specialists recommend is usually a structural MRI, where a person goes into a scanner and images are taken of the structure of the brain. And that tells you about, let's say, for example, if there are any tumors, if there are any abnormalities in the structure of the brain. That is not the kind of MRI that we use. We do take structural images, but on top of that, we use a functional MRI. And a functional MRI is different in that it doesn't just look at the structure of the brain, it also looks into the connectivity between different areas of the brain. And how an fMRI does it is it usually measures the level of blood, or the oxygenated blood in your brain. And it can infer what areas of the brain are usually in connectivity with one another, or basically talking to one another. So you can think of it this way. Let's say if you are engaging in a certain task and a specific area of your brain is doing that task or is helping you do that task. That area, since it's working, it would need more oxygen and more blood. And so the fMRI, the machine, can actually detect those changes in your blood oxygen levels in the brain. And so it can make inferences about what areas of the brain are talking to each other or how they're connected to one another. And so what we usually do is we get our participants and we put them in a scanner. The method that we are using is called a resting state fMRI, which means that the people are in the scanner with their eyes closed. So we give them clear instructions. They have to keep their eyes closed, but they should not fall asleep. And they shouldn't think of anything in particular, not fixate on any particular thought, let's say. And then we take a scan of their brain and we try to explore what regions of the brain are connected to one another. In our study, we compared one Charles Bonnet patient with a group of healthy participants within the same age group. So all our participants were between 70 to 85 years of age. And we found that in the Charles Bonnet patient, there were definitely differences in the connectivity between areas. And this has been well documented in other studies. But the issue is that the results are usually very variable. For example, there is a network in the brain called the default mode network. And this specific network is a resting network. So it's usually activated when you're not doing anything, you have your eyes closed, you're just relaxed. That's when this network actually gets activated and is at its peak activity, basically. And there are other networks in your brain that activate when you're actually engaging in activities, right? And so you need a perfect balance between those resting networks and those task-related networks. So there needs to be an on and off, a synchronized on and off between them in order to perform your normal functions in your day-to-day life. And what we do is we usually measure the connectivity between those areas, between those resting state areas. But the findings in the literature have been very variable. For example, there was a study that was published in 2019 by a researcher named Charlotte Marshall in the journal PLOS ONE. And they found that in Charles Bonnet syndrome, the default mode network was actually, there was a decrease in activity. There was an increase in activity, in the default mode network, with specialized areas of the brain that basically recognize faces or patterns or objects. But in our study, we actually found the opposite. We found that areas within the visual brain were actually less connected, or they were anti-correlated, as we call it. And I think that while there is a lot of variability in the results, I think it's because Charles Bonnet syndrome is extremely multifaceted, and we need to understand the etiology of why a person developed Charles Bonnet syndrome. So in the study that I was just talking to you about, the Marshall study of 2019, the patient that they were assessing actually had retinitis pigmentosa, which is a disorder of the retina that occurs at a very young age. So potentially the person could start from the manifestations of the vision loss from a very young age, maybe up to 10 years old. But in our case, for example, our patient, he had a myriad of different eye diseases. He had age-related macular degeneration, he had glaucoma, he also had cataracts that was operated on. And so when you have two different studies with patients who have two very different eye diseases, when you see differences in the results, it's not really surprising in a way. I think that the problem is that we don't have large-scale studies that look into the different eye diseases that cause Charles Bonnet syndrome and look into the details of brain differences because of those diseases. For example, it has been well documented in the literature that people with age-related macular degeneration, they do have alterations in their brain, but these alterations are usually at the back part of their visual brain. If you compare them to people with glaucoma, let's say, people with glaucoma also have changes in their brain, but they're more towards the front part of the visual brain. And so when you have a CBS patient who has a combination of age-related macular degeneration and glaucoma, and then maybe or some other eye pathology, it becomes very difficult to separate the different connectivity patterns of the brain and to say why different patients have different manifestations.
That is fascinating, all of the stuff that you were just talking about. So I would like to talk about the fMRI. So is that something that is experimental? I've never heard of that. I've just heard of a regular MRI. How common is that procedure?
So it's mostly used in research. It's the same. So in terms of the equipment, it's the same machine. It's the same scanner. It's just a difference in protocols. So before we scan a participant, there's a lot of work that goes into the protocol that needs to be used. There's so many aspects related to the physics of how the machine acquires images, right? While it is the same machine, it's the same scanner, but it's usually used in research, not very much in clinical settings.
Okay. And another thing that came to my mind is, as I was just reading some literature, I came across something that said you can pass an MRI and it shows that your brain is structurally sound, but the brain may not function well. I found that quite interesting. So I don't know if you have any insight into that. Obviously, from my perspective, that would mean that everything looks good, but it's not operating well. So do you have any insight into that? Because some people can say, I took an MRI, everything is okay, but maybe it's not.
Yeah, so they're definitely two different things. So having a structural MRI is different than having a functional MRI. They look into two very different things. One looks into the structure of the brain. The other one looks into the functioning of the brain. But at the same time, they complement one another. But also, let's say, for example, it has been documented that, let's say, there are certain regions of the brain that lose volume when a person experiences hallucinations, let's say. So they basically shrink, they lose volume. So you could potentially see that in a structural MRI, right? But at the same time, in order to make inferences and for this information to be meaningful, you need to correlate it with function, right? An ideal scenario would be to look into the structural integrity of the brain and how different regions, how they maintain their volume or maintain their structure. But you cannot get a complete picture without looking into the function and how that particular area that has lost volume, if it's connected to other areas of the brain the way it's supposed to, or whether there is some form of maladaptive connectivity between regions. So they definitely complement each other. But to answer your question, yes, a structural MRI may not be enough to look into the function of certain brain areas.
The brain is so complex and vision is complex because as I talk to different doctors and different professionals on this podcast, they all explain that you see with your eyes, but you also see with your brain. And it's so much going on and it's hard to just quantify. Like once I asked someone that was a medical professional and also I asked someone that had Charles Bonnet, like, how much sight do you have? And they said it's hard to say because there's so many factors that can go into sight. And how do you measure that? Obviously, some doctors do put it in words. I think you have about 20% of your sight left, but there's a lot of factors. Some people have night vision, some can't see at night, some people during the day, some people see like a funnel or something like that. There's so many different factors. So it's just these things, I don't know. It's just when you have something like this, if you were trying to maybe figure out a way to make a different kind of cast for a person's leg so it would heal quicker or it wouldn't overheat or whatever, I would think layman's terms again, or someone that's not a doctor, that could potentially be easier than studying the brain and vision and visual perception and hallucinations and things like that. But I know that we're smart, we're intelligent, and doctors like yourself or soon to be doctor and other people are going to do this. And even some people that are not doctors can help contribute in some kind of way, however it is, whether it's contributing to a study, sharing your story as a person with CBS or caregiver or donating some money to somebody. There's a lot of ways we can all work together to help this condition.
Yeah, for sure. Yeah, I agree 100%. Yeah, the brain is very complex. 100 billion neurons, and they're connected in amazing ways. And any disruption to any network or to any small brain region could lead to cascading effects and cascading consequences. You know what I mean? So it's extremely complicated. It's fascinating. But I think that there are amazing researchers out there. And I hope that the work that we're doing is adding some information, adding some knowledge to this ocean of literature that's out there. And hopefully we're getting there.
It definitely is adding some. And sometimes it seems like you're not making progress or you're not doing everything that you hope to do or things are moving slowly. And there's more progress than you realize for people like yourself that are researchers and even people from the outside looking in like myself. It's, oh man, nobody's doing anything for people with Charles Bonnet syndrome. And sometimes I talk with other people who do things and help, whether they have an organization or a caregiver. But then I'm reminded when I have this podcast and I talk to people like you, or I talk to other people that have organizations or support groups, there's a lot of people that are doing things and we just don't know that. So it is definitely helping.
Yeah.
One thing that I would like to talk to you about, I have participated in dozens, probably well over 100 support group meetings, the support groups that allow me to attend, because some are just for people with CBS and some are for caregivers or anyone that has an interest. So I have attended support groups, and I hear more often than not is this. I don't really want to put a number on it, but there's a good amount of people that tell me they experience multi-sensory hallucinations. And all of the literature from the experts say that Charles Bonnet is just silent visual hallucinations. And that's what it is. I'm not going against that. And that's what I believe. But more and more, I hear people saying that they feel their hallucination touch their leg or they hear it. And I was just curious. A lot of people have different perspectives on this, but what are your thoughts on that? Do you think there's more research that needs to be done? Do you think it's comorbidities and there's other things going on or anxiety causing it? I'm just curious. What is your insight?
So there is a diagnostic criteria that is mentioned out there in the literature to diagnose CBS. It's a 5-point criteria, and I can talk about the 5 points briefly. And what I want to discuss is that there has been an ongoing debate about the applicability of this criteria and whether we need to take a step back and think about revising it or changing it a little bit. And I will elaborate on that a little bit. But first, I will just state the criteria. It's a 5-point criteria. The first criterion is that there needs to be one complex hallucination that occurred within the past 4 weeks. So let's say a patient comes in into the clinic or to a healthcare provider. They should have had at least one complex hallucination within the past month. The second criterion is that there should be a period of more than 4 weeks between the first and the last hallucination. So if a person comes in, they've had their first hallucination 2 weeks ago, and then they had their last hallucination on the same day where they visited a healthcare provider, then they wouldn't qualify or they wouldn't be diagnosed with Charles Bonnet syndrome, because Charles Bonnet syndrome hallucinations need to extend over a longer span of time. The third criterion is full or partial insight about the nature of the hallucinations. And what that means is that the patient should be aware that the hallucinations are not real. Now, you may ask me, okay, so why does it say full or partial? And the reason for that is because most of the people who start experiencing CBS hallucinations, in fact, 80% of people who start experiencing CBS hallucinations, they immediately know that the hallucinations are not real. They're completely aware that this is a strange phenomenon, but they are aware that the images are not actually there. But the remaining 20%, some of them do experience some confusion initially when they first start experiencing those hallucinations. But eventually, that 20%, they usually realize that, okay, now I realize these images are not real. They're just hallucinations. They don't exist in reality. And I think this point, like this criterion, is important because there are so many other hallucinoses or so many other disorders where patients experience hallucinations, but they're completely different. They're not the same as Charles Bonnet. And let me give you an example. In one of the disorders, it's called peduncular hallucinosis. It's where people experience complex visual hallucinations and they're completely aware that the hallucinations are not real. So here, there is a commonality between CBS and this form of hallucinosis. However, there is a difference between them where in peduncular hallucinosis, people usually experience disorientation, a little bit of confusion, and they also have some mild cognitive impairment. In some tests related to short-term memory, for example, they could have some impairment in their cognitive abilities. It is important to look into this specific criterion in diagnosing CBS, because just because a person has insight about their hallucinations, it doesn't mean that it's automatically Charles-Bonnet syndrome. It could be something else. So it is important to look at other aspects. It's important to look into cognitive functions, cognitive abilities. And I think this further highlights that CBS is a very nuanced phenomenon. And one healthcare provider cannot work alone to manage CBS. It's very important that we have an interdisciplinary, holistic approach where neuro-ophthalmologists and neuropsychiatrists and different healthcare providers come together to come up with the diagnosis of CBS and to be able to properly manage the disorder as well. The fourth criterion that I wanted to talk about, and I think this is a little bit of a sticky one, it's the absence of hallucinations in other sensory modalities. And this means that in order for a person to be diagnosed with CBS, they should only have visual hallucinations. Now, in the literature, there have been several case reports of people who experience visual hallucinations along with auditory, which means hearing hallucinations, and even tactile hallucinations, which basically means touch, hallucinations related to touch. Just to give you an example, there was one case study that was published in the Indian Journal of Psychological Medicine. And it was a case study of a 72-year-old female who had visual hallucinations. And she could also hear people crying at times. And she could also see snakes. And she would see the snakes kind of attacking her. And they would spit venom on her. And then she would be able to feel the venom on her skin. And it would burn her skin. And yes, people who have auditory hallucinations, it's usually associated with hearing deficits as well. So normally people who have visual and auditory hallucinations would have some form of hearing impairment. But when you're talking about a population that's above 70 years of age, or majority of them at least, above 70 years of age, I think we are doing a disservice to the people when we say that if you have auditory hallucinations, if you also have hearing hallucinations, then you do not have Charles-Bonnet syndrome. I think we're doing a disservice to them. It has been well documented, whether you want to talk about folklore or you want to talk about actual scientific research. We've all heard about this. Keep CBS aside. If you talk about blindness, let's say, we know that we've always heard that people who are blind, they have superior hearing or they have superior sense of touch, right? Mm-hmm. And it's something that we call cross-modal plasticity, where if you have a disruption in, let's say, the visual part of your brain, other areas, other specialized areas of your brain, which are responsible for hearing, for example, they start forming amazing connections with different areas of the brain. And those connections did not exist in the past, but they start developing those connections as a result of that disruption. So we know that the brain has this ability to change, to mold, to form new connections. And I think to say that people who have hallucinations outside of the visual realm, to say that they do not qualify as CBS patients, I think that's a little bit of a stretch, personally. Again, it's my opinion, but there are several researchers as well that have coined the term Charles-Bonnet plus syndrome, which means people who have visual hallucinations, they have Charles-Bonnet syndrome, but at the same time, they could potentially have other hallucinatory experiences across other sensory modalities as well. So again, this is why I think now the diagnostic criteria has been there for a very long time. Papers in the late 1990s have mentioned the diagnostic criteria. But I think we're in 2024, and I think considering all those case reports, considering those experiences that we hear from people, I think that we need to keep an open mind and potentially consider revisiting the diagnostic criteria and to think about who qualifies or does not qualify as a CBS patient. In fact, just one last thing about this whole one topic. In our survey study that we had conducted, we collected a lot of data from 55 participants around Canada. And they provided us with detailed descriptions of their hallucinations, of their experiences from the time, from the onset of the hallucinations until the time when they actually filled out the surveys. And out of 55 participants, 65% reported that they had multisensory hallucinations. And I think that says something. I think that when the data speaks, when the data tells you something, we need to listen and we need to keep an open mind and we need to explore the possibility that people with CBS could also have other sensory hallucinations.
That's fascinating what you just said and how you explained everything. And I just appreciate that. One thing that I would like to say is when I was in these support groups and people mentioned that they had tactile hallucinations or auditory hallucinations, some of the leaders of the groups or the special guest presenters were saying that it could be CBS and something else. I hadn't heard people actually say you don't have CBS. So that could be a little bit insensitive to that people would say that, because almost any condition could possibly be accompanied by something else, possibly. And then another thing I want to say, when I was reading Oliver Sacks' book, Hallucinations, he was mentioning that anxiety can cause hallucinations, and also being sleep deprived can cause hallucinations. And he's given examples in his own life from some other patients that he's had and he was aware of. When you have CBS, if it's a severe enough case and it really causes a lot of trauma and stress in your life, you're not really sleeping well, because a lot of people, when they're relaxed, is when they have the hallucinations or when they wake up to go to the bathroom or turn over in their bed and they see something, it might frighten them. So then they're scared to go to sleep, or they may have a heightened state of anxiety for a long time. And when you have severe anxiety for a long time and you're sleep deprived, it is a possibility that you could have some hallucinations. So it's so many factors and things that could be coming into play when someone has Charles Bonnet and they're experiencing these hallucinations.
100%. And if you think about it, there is something known as musical ear syndrome. And it is when people have hearing deficits and then they start experiencing auditory hallucinations, right? I'm not saying that people can only have auditory hallucinations and for it to be CBS. I'm saying that we have to keep an open mind that, as you said, there are so many nuances, there's so many pathologies that could coexist in one person. And we need to look at CBS from a different lens, and we need to think of it as a broader umbrella where multiple different manifestations could occur within that broad CBS umbrella.
Yeah, and I've heard some people say, oh man, CBS is hard enough, and now you're telling me I have something else. And of course, we aren't making any diagnosis because we're just on the call. And so are the leaders of the groups and stuff. They're just saying it's a possibility, but obviously go to your doctor. But then when you go to your doctor and they don't know about CBS, that's challenging too. And some doctors actually know about CBS, but they say there's really nothing that can be done. And they say that some of the medicine that they give to treat CBS helps people, but it doesn't really last. And sometimes it does more harm than good. And obviously, when we start talking about medicine, that's something you have to talk with your medical professional. And I'm thinking possibly, not just me, many others think this too, when you have a condition where you don't really have a real good known cause aside from the vision loss and you don't have a treatment path. And I was even looking up the difference between syndrome and disease. And disease is more established and they know why you get it and they have treatments for it. With syndrome, it's like some people may not even really think that syndromes exist. You know, it's like unproven and they don't know. So a lot of doctors seem to not want to do anything about it. And some doctors have said, yes, you have CBS, but there's nothing I can do to make the hallucinations go away. I can understand if you're going to the urgent care clinic or something like that. But if you're going to see a neuro-ophthalmologist, you don't really want to hear that, even if it is the case. So yeah, it can be. It's a lot of challenges with this condition, but people like yourself are making a huge difference. And Dr. Steves, too, we interviewed her on the podcast. She's doing a lot of great stuff. With your research, when you're doing what you're doing now, do you actually have to lead this research in order to finish getting your doctorate? Or do you work with a team?
So we definitely do have, of course, we have a lot of other graduate students. We usually work very closely with our colleagues who are grad students. We work closely with our supervisor, of course, Dr. Jennifer Steves, and we have a lot of undergrad students as well who help us when it comes to conducting the research. So let's say, for example, I am taking the lead on this project. So whenever I have patients coming in, let's say, I usually have my colleagues around me who help me with, let's say, meeting up with the patients or interviewing them just to give me a helping hand when I'm like with the patients. So while I'm taking the lead, but definitely it takes a whole team to basically finish the research project or to polish it, let's say.
That's really great. Is there anything that you would like to discuss that we maybe haven't discussed yet?
I want to talk, since you mentioned the treatment approaches, I think I want to elaborate a little bit on that, maybe about what's out there in the literature about it.
Certainly. Tell us a little bit about treatment and give us some insight into that, please.
Okay, so as you know, there's no current definitive treatment for CBS. Some studies report that there are certain triggers to the CBS hallucinations, like, for example, in some cases, being in a bright environment could trigger the hallucinations. But generally, I would say the first line of action or the first thing that we recommend or is recommended to patients is that they follow some mitigation techniques. So I'm sure you must have heard about it, looking directly at the hallucinatory image or moving one's eyes or blinking, walking towards the hallucinations. But of course, these are highly subjective. They do not work on everybody. Actually, one of the patients that I personally met, he told me that he uses an eye mask when he sleeps at night to stop the hallucinations. And he said that closing his eyes and putting the eye mask on in complete darkness, it actually helps him, especially before he goes to sleep, and it stops the hallucinations. But of course, it's not always successful, and they don't always work with everyone. On the other hand, there are so many other pharmacological interventions that have been tried. Like people have prescribed antipsychotics, let's say, or anticonvulsants. And there are case reports in the literature that show that they sometimes partially or fully stop the hallucinations. But again, there's no consistency in their effect, basically, to eliminate CBS hallucinations. I think a very important aspect to treatment approaches, especially when it comes to pharmacological interventions, is that most of the studies that we see out there are usually case reports. And in a case report, you would have 1 or 2 or 3 patients, and you would try, let's say, a pharmacological intervention on them, and then you would see if it works or not. And I think what we're lacking in the field is large-scale studies. We need large-scale, randomized, controlled studies where we study a huge group of participants and we study many different variables like dosing, for example, dividing people into different groups based on their etiology or why they got the Charles-Bonnet syndrome to see whether certain pharmacological interventions, let's say, whether they work on one group as opposed to another. And finally, the last thing that I wanted to say about treatment approaches, one very promising approach is actually the non-invasive brain stimulation techniques. There have been a few studies. There are not many studies. Off the top of my head, I can think of 3 studies that were published where they used either TDCS, which is transcranial direct current stimulation, or they've used TMS, which is transcranial magnetic stimulation, to try to eliminate hallucinations. And the results have actually been very promising, where people have reported that CBS hallucinations were completely eliminated after using those non-invasive brain stimulation techniques. But again, we still need large-scale studies because even within the non-invasive brain stimulation techniques, there are, first of all, many different protocols that can be implemented. And also dosing is a problem. We still need to figure out what is the appropriate dose of brain stimulation that needs to be administered for us to see the most optimum results. In fact, just an example from our lab at York University. So we use a stereotactic neuronavigation system before we do the neurostimulation. And what that means is we put people in an MRI scanner first, and we take images of their brain, structural images of their brain, and then we input that image into our neuronavigation system. And by doing that, we basically can see on the screen live while we're doing this, the stimulation session, the brain stimulation session, we can see exactly where we are targeting the stimulation. So it's a very focal technique. We can see the intricacies of the brain, literally every curve and crevice of the brain, and we can target the stimulation to a specific area of the brain. This neuronavigation technique, it's actually a surgical tool. It's used in surgeries, neurosurgeries, but we are using it in our lab. We haven't used it in Charles-Bonnet syndrome yet, but TMS in general is FDA approved for depression. It has been used widely in depression. And I think that if we can conduct more researchers around the world, if we can figure out the protocols that we can use for non-invasive brain stimulation, and if we can figure out the dosing of the brain stimulation techniques, I think it can be a very promising approach to hopefully mitigate or eliminate Charles-Bonnet syndrome hallucinations.
Thank you so much for breaking that down like that. And I'm sure people are going to get some insight and figure out some things that they could potentially do or talk to their doctor about, or even some things like you mentioned, the eye mask, which I have mentioned and many other people that have spoken or help people with Charles-Bonnet have mentioned. And sometimes it works, sometimes it doesn't. And what's interesting about Charles-Bonnet is something can work for you for 1 month straight and then it could just stop working.
Yeah.
But you have to try and you have to keep positive and think positive. I also like the fact that you said you would have to take like a holistic approach. You can't just take a pill because most of the time pills don't work anyway, but maybe talk to a therapist and maybe take some natural medicine or something, or even if it's a tea to relax yourself or something, and go to a support group. It's not, at least at this stage, just like a one size fits all or one pill that can solve this. That's very important that you mentioned that.
Yeah, for sure. I think that, it's definitely not a one-stop shop where you can go and solve all your problems and resolve the hallucinations, for sure. I think that as healthcare providers, as researchers, we need to come together. We need to do the best we can. I think that there needs to be a change even in terms of maybe hospital policies and how patients are referred from one department to another or from one specialist to another. I think that there's a lot of work that needs to be done at a policy level when it comes to healthcare, and even at a researcher and healthcare provider level as well, for us to try as much as possible to manage Charles-Bonnet syndrome as best we can.
Some people call Charles-Bonnet an orphan disease because they say it doesn't really affect a lot of people, even though it affects millions of people. But it's hard to get an accurate number. And then you have to say that maybe in the world, whatever it may be, like you said, 2 billion people that have some kind of visual impairment. To have a severe enough visual impairment where you get Charles-Bonnet is a smaller percentage of the population. And then of that, it may only be 1/3 of those people that get the condition. So as I was talking to other people that are advocates and that are trying to champion some change, they were saying that's difficult because if you have, let's just say, I don't really want to mention any names. So let's just say you have a big drug company that makes billions of dollars. They may not want to take money or put resources into doing research for something that is not going to give them a return on their investment. So this is a long way to ask a question. Really, what I wanted to know is, how do you think we can get some more large scale studies? Because you mentioned that if we had some large scale studies that could help, will we need donors to donate some money, or would it have to be more beneficial for these pharmaceutical companies to get involved?
So I think that, personally, I think that we could look into avenues that have not been looked into as much. For example, as I said, the non-invasive brain stimulation techniques, they're very helpful. And despite that, you don't see a lot of research out there. And it could be a funding issue because in general, having a patient population and studying a patient population is expensive. If you think about getting people in the scanner and getting them scanned and getting them in multiple times for different treatments, let's say if you want to test the brain stimulation techniques over a period of time where you call them in multiple times a week for several weeks, that all requires funding. So the research process in itself is extremely expensive. And unless appropriate funding is provided for this research to flourish, it's going to be very difficult to make progress. And so I think that, yeah, as you mentioned, I would say funding is very important. And I believe that the more we spread awareness about CBS, more people will come forward and report it, and more people will actually speak to their healthcare providers, or the word is going to spread. People are going to know more about it. It's going to be more prevalent. And maybe that would lead to an increased interest in terms of funders, generally government funding and things like that, to promote the research and to hopefully do better for these people.
That's so true. It's amazing being an advocate and spreading awareness, what you can do, because you never know who's listening or who will listen, how you can reach someone. And then somebody could say, that sounds like what my mom had. She died 10 years ago, but she was experiencing things that we didn't know. Because I'm a caregiver for someone that has it, and I immediately thought it was dementia. And I actually reached out to the Alzheimer's Association and was talking to people. And I was just about to start going to support groups. And then I found out about Charles Bonnet syndrome. And I said, wait a minute, this sounds exactly like what my loved one has. And I was able to confirm it was and went down that path to figure that out. I found some videos, actually went to YouTube and then found some videos on YouTube. No, I actually went to Google and then found some videos on YouTube a little bit later. So the more information out there, the better.
Yeah. And it's quite sad. People are afraid. People do not come forward. They do not express, or they do not tell anyone about their experiences for years, for decades sometimes, because they're worried that people are going to think that they're mentally unsound. And so honestly, like, you never know. Maybe there's a much larger segment of the society that's actually suffering with CBS, but we just don't know. And just because they're not coming forward, we think that it's not very prevalent. And so maybe there's not much importance that's given to CBS because people think that it's a very rare disorder. So why should we put a lot of funding into it when it's extremely rare, right? But yeah, it's quite sad. And generally, I think what the work that you're doing, trying to spread awareness through this podcast, I think that we need more of this so that we can spread the word and so that we can help those people.
And also the word hallucination has such a negative connotation. And at least in Western culture, I don't know about the East, because I was thinking about that too. Like, some cultures might be more receptive to hallucinations. I mean, they may call them visions, or some people even think it's spirits. I've had people that have CBS clearly that were thinking it's spirits. And I'm not into telling someone they're right or wrong, arguing with them or anything like that. But sometimes that can make things maybe a little more challenging. But I understand you got to meet people where they are too and allow them to express themselves, be patient and show some love. But different cultures may treat things differently. So maybe if you are in an Eastern culture, you can talk about, if you said, hey, I'm seeing something, maybe it might potentially be accepted more than a Western culture. I don't know, but it's a shame that it has such a negative connotation. There's so many things that have changed over the years in society, whether it's sexual orientation being more accepted, or whether it's race relations, or, and we have a long way to go with everything. But the word, just like also therapy, at least in America, it was like you didn't talk about it 20 or 30 years ago. And now it's cool to go to a therapist. I'm hoping that people will not be ashamed to talk about hallucinations. And especially if you have a visual impairment, you can say, wait a minute, I should really look into this. And then I think that it could, well, not I think, based off what you're telling me and what many other people are telling me, once you realize what this is, it's a relief. You still go through the stress, especially if you have hallucinations that are frightening, but it's a relief to know, like, okay, I don't have dementia. I don't have anything, schizophrenia or something like that.
Yeah, and definitely speaking to what you said about the cultural aspect of it, definitely, especially in the East, there's a lot of cultural, religious, spiritual aspects to visual hallucinations. Of course, it is highly stigmatized. People don't want to be labeled as mentally ill, or so they sometimes come up with explanations or to say that it's something religious or something spiritual. Or there have even been case reports where people say that they see gods or ghosts or things like that. So definitely there's a huge barrier when it comes to the cultural aspect of it. But I think that with time, if it becomes well known and people know more about CBS, I think that we can debunk all of those things and we can actually overcome them to hopefully do the best to manage CBS hallucinations.
Thanks so much for your time and thanks for everything that you're doing. And I'm just glad that you're doing the research. You took the time to talk to us. You took the time to explain a lot of things and bring a different perspective to this podcast. And people tell me this podcast is helping them. They listen. It's encouraging. And I'm definitely going to keep it going. I'm going to add your email address in the show notes, if you don't mind, just in case anybody wants to reach out to you, if that's okay with you.
Of course, yes, that's okay with me. And I also wanted to thank you, Shaimond, again for the invitation, for having me. And thank you for all the work you're doing and for all your effort. And this is what we need. This is what we need to spread the word and to increase awareness about CBS.
It was much appreciated. And thanks again.